Hi, thank you for joining us. Welcome to the show today. The show is Your Key to Healthy Living, Marquis Presents with Karen Halloran. And I am here today with Dr. Adam Smith and with Steve Alexander, pulmonologist.
Thanks for having us, Karen. It's a pleasure to be here.
Well, thank you. Thanks for coming.
Yeah.
Thanks for coming, Steve.
You bet.
And so I brought you on the show today because a lot of people have questions, especially with this season, about COPD and breathing and all of that. So I thought we could talk about some of those things. But I thought at first, let's get a little bit of your background. Where did you go to school and what got you interested in pulmonology?
Sure. So I did undergrad at Tufts, and then I went down to the New York area, went to NYU for medical school, and stayed in New York for the rest of my training. And then when I finished up, I came to the Boston area, and I've been in practice ever since. So I spend most of my time in the office treating folks with respiratory ailments, people who are coughing or they're short of breath. And a lot of these folks are suffering from COPD. So COPD stands for Chronic Obstructive Pulmonary Disease. Have you heard of that?
I have heard of that.
All right.
Unfortunately, we do have a lot of people that suffer from that and come into our centers.
Yeah. So I think it makes up the majority of the people that I'm taking care of. They're suffering from COPD, and COPD is essentially smoking-related lung injuries, and there's kind of two aspects to it. The one aspect is what's called chronic bronchitis, but chronic bronchitis really relates to chronic inflammation and cough and sputum production, and so inflammation triggered by years of smoking. And the other aspect of COPD is emphysema, and that's loss of lung function and loss of the small airways from airway destruction from smoking over the years. So those combined lead to the symptoms from COPD. People are experiencing shortness of breath, cough, wheezing, and so forth.
So maybe we could just back up and say chronic obstructive pulmonary disorder for people that don't know that, right?
Yeah.
Because we tend to, in the medical field, just bring out all these acronyms and things like that, and people don't really know. So what exactly is the chronic obstructive pulmonary disorder? I mean,
Yes.
It's all really caused from smoking?
In the Western world, it really is almost exclusively caused by smoking. In some third world countries where people are cooking on fire pits that don't have good ventilation, that can be a cause for COPD. But fortunately, we really don't see that in this country.
Just to dovetail a little bit about what he's talking about, some of the root causes. In this country too, I mean, the Surgeon General came out with a report back in 1964 about cigarette smoking and the deleterious effects that it has on people. But there's different occupations too that can lead to problems, namely borreliosis, which was a disease that was prevalent around here because of the Sylvania factory. Early on, different occupations, whether it be farmers working with hay or coal miners' disease down in the south. Secondhand smoke for non-smokers is certainly a task that we've been grappling with. You may recall that Christopher Reeve's wife passed away. She was a lounge singer, never had a cigarette in her life, and she died from lung cancer.
Wow.
Worldwide, a good 5 million deaths, I think, associated with COPD. It can be very insidious, and I think it's probably worth talking about how vulnerable our lungs are to begin with, without smoking, with the air pollution that we have and microwave activity and, like I mentioned, secondhand smoke. And it's very insidious, and it's usually not detected until the individual realizes that their level of activity has been impaired, be it walking to the mailbox, or they can only play one set of tennis as opposed to two, or only 9 holes of golf. It's very, very insidious, and it's not detected really until the disease gets to the point that they're symptomatic. They seek a doctor, and then the disease is staged by way of pulmonary function testing, which we can probably allude to a little bit later.
So that's how it's really detected, is people find it's interfering, their breathing is interfering with their daily function. and go to a doctor.
Exactly. Like Dr. Smith said, you might have the wheezing, the congestion, the shortness of breath, and these are telltale signs that it's early stages of lung disease.
And so how are these treated? Do you want to get into the treatment of it?
Certainly, I guess I have it. I want to step back a second and just make an observation that I see in practice, and that is, fortunately, I think we live in a society where we've recognized the ill effects of cigarette smoking. So most of my patients stopped smoking 10, 20, even 30 years ago,
Right.
and what's frequently the case is they didn't develop symptoms 20, 30 years ago. They've developed symptoms in the last 5 to 10 years. And that is oftentimes hard for them to internalize because they see smoking as having been a remote period of their life.
Right.
And now it's affecting them now. And how does, how do they wrap their heads around that? And my explanation for that is the following. What I tell everyone is, we're born, our lung function peaks by age 35. And after age 35, all of our lung function is going downhill. Mm-hmm. And in the years that people were smoking, they're losing more lung function. They ultimately stop smoking, but they then continue to lose lung function at a more normalized rate. And so that people don't feel so bad about this, I also say, hey, look, our knees are aging, our hips are aging, and so we're losing lung function. Our lungs are aging. So that's how, in a way, people can say, it caught up with me, or
Right.
There's that delay in presentation with symptoms. Mm-hmm. So that's one thing that I think is hard for many folks to wrap their heads around. Mm-hmm.
Well, I'm sure it is pretty discouraging for somebody that quit smoking 30 years ago, then all of a sudden get hit with this. It probably was a small point in their life that they used cigarettes. So it's terrible.
But truly, you can only get away with it for so long.
Right.
Your air sacs in your lungs, you have 300 million of them. That could cover a tennis court. Like I had mentioned, your lungs are very vulnerable. There's nothing between your nose and your mouth to really help protect your lungs. You have your ribs to protect your heart. Your kidneys are hiding away.
Right.
But your lungs are very susceptible to anything that's airborne.
Right.
So those 300 million sacs that are involved with gas exchange, you can lose 20% of it, not know it, 25% of it, not know it, but then you get to the stage that you only have so many left, and you got away with it for so long, and then it's got you.
All of a sudden it's terrible.
Yeah.
That is terrible. Seems like it just kind of sneaks up on people.
Yeah.
And then what I find to be the added factor is that perhaps someone then develops a significant respiratory infection that has them laid up or even hospitalized, and from that hospitalization, they may lose muscle mass. And now, you might notice that in their thighs or their biceps, but they're also losing muscle mass in their diaphragm. So those are the respiratory muscles. So now the support structure for the lungs is also weakened, and that really can be a setback for folks with COPD and lead to worsened breathing.
Right. I never thought about that diaphragm. Yeah. It's true. So how would people be treated? I mean, obviously, I automatically think of oxygen. I'm sure there are many more things that we do than oxygen, right?
So obviously there's definitely a role for oxygen, but we can think about medications that can be helpful. We can also we need to think about, are we treating someone for the long term, a maintenance treatment, or are we thinking about an acute flare-up,
right?
And managing that maybe with antibiotics and anti-inflammatories to help there, and oxygen oftentimes. But and then maintenance therapies would involve inhaled medications frequently. Mm-hmm. But beyond that, there's a lot of prevention, getting vaccinated, maintaining exercise and quality of life and physical rehab.
So you just mentioned vaccination. So you're talking about vaccination for pneumonia,
influenza,
and all of that.
Yeah.
A lot of the key factors that we have to keep in mind is good nutrition and, as Dr. Smith mentioned, activity. But you also have to be aware of the triggers that may produce what's called an exacerbation of a pre-existing disease. And these triggers can be something as simple as the weather, pollen, airborne talcs or sprays,
Air quality. Sometimes
the
we
air,
get those
the
air quality.
Colds and flus.
I mean, I'm sure you've driven down the street and see somebody mowing their lawn, and there's all sorts of dust and
Right.
dirt and grass flying up in the air. These are things that could trigger somebody who's sensitive, number one, whether they have lung disease or not.
Right.
So wearing masks or wearing a scarf in the cold weather, which can induce bronchospasm or narrowing of the lungs. You mentioned oxygen therapy. Yes, I mean, that if the patient gets to the point that they need that, there's very many options nowadays for its portability and use at home. Other options are when their lung disease gets to the point that they have difficulty ventilating, especially when they sleep. There's called BiPAP therapy, which is like an adjunct to CPAP, which a lot of people are familiar with, especially with these cleaning devices that they have nowadays. But BiPAP is a way of helping your lungs rinse the carbon dioxide while you sleep so that you wake up feeling a little more alert, because that's one of the problems with COPD. The dysfunction leads to carbon dioxide retention, and that's what your lungs are designed to do, get rid of the poison. Carbon dioxide is a result of cellular metabolism. So if your lungs are having difficulty eliminating carbon dioxide, it builds up in your blood, it leads to fatigue. So it's not just the oxygen supplementation that you need to be concerned with, it's the elimination of the carbon dioxide. And a lot of these medications that are on the market now, and how many inhalers do we have now? 20,
Endless.
25?
Really?
I mean, every...
What are some of the names of the inhalers?
Oh, there's short-acting ones, Prevental,
Okay.
known as albuterol as well,
Right.
Duoneb, there's Atrovent. Some of them work as anti-inflammatories, which help reduce the swelling. Some of them work on bronchospasm, the smooth muscle that surrounds the bronchial tree. Some are designed to affect certain receptors in the lungs. There's a whole host of medications, as well as steroid therapy that
Right.
Dr. Smith can allude to.
Well, it's unfortunate that it happens, that it catches up with, because I think, when people were smoking, they didn't know it at the time. And so unfortunately, and then the different situations we have. So we have a lot of people that come to the centers that we have at Marquis. And Steve, you're the respiratory therapist at them. When do you see somebody come to us? Why would somebody come to a skilled nursing facility?
The majority of patients that I'm involved with have recurrent hospitalizations for their COPD. And as Dr. Smith had mentioned, the time period that you spend in a hospital when you're not up and around and you've suffered a bronchial infection or blood sepsis or post-operative problems, you tend to atrophy. Your muscles get weak. And part of the programs are designed to rehabilitate their musculature. I try to give them some tips to make them better breathers. Like I mentioned, some of the triggers for them to avoid. Relaxation. A lot of these patients are high anxiety, as we can understand. Having difficulty breathing leads to anxiety. So we try to give them some relaxation and some guided imagery and some tips to try to calm them down, especially when they have a flare-up. So these buildings are designed as a multidisciplinary team to approach nutrition, physical therapy, nursing, and my component, respiratory therapy.
It's funny that you mentioned nutrition, because I wouldn't really have thought of that off the bat, but it is really important, definitely.
Yeah, very much. I mean, for the folks that have lost weight and lost muscle mass, rebuilding and providing adequate nutrition is essential. And for those who actually, corticosteroids and prednisone has the negative side effect of gaining weight.
Right.
So helping people, get back to their normal weight is also part of the goal, and rebuilding muscle mass. So the Marquis facilities serve as a great bridge for patients who are unable to get home yet and need to strengthen their system before they can do so.
Right.
And it doesn't end at the discharge from our facilities. That's a beginning for them. They need to continue with these things at home or extend to an outpatient rehab facility. There's a few on the North Shore that I don't mind mentioning.
Sure.
Leahy has one in Danvers at the Wellness Center. They have an outpatient program, and people's insurance will cover 12 weeks, I believe,
Oh, that's good to know.
2 days a week. North Shore Medical Center, part of the Partners Group, they have a pulmonary rehab outpatient center on their campus on Linfield Street right now. There's also one it'll be transferring to Salem because there's some transitions over there. And Anna Jake has one. They're out there. And
Oh, that's so good to know.
Yeah, people need to know that.
Yeah.
Absolutely.
And what I tell folks about those programs is that, unfortunately, people need to relearn how to exercise safely. So it's not ideal that you just go to a gym and overexert yourself by having an exercise program where you're supervised, maybe with oxygen, supervised by nurses or respiratory therapists. And learning appropriate coping techniques will enable people to go home safely and have an improved quality of life.
You don't need a set of weights at home. You can simply take empty milk jugs, gallon milk jugs, pour in as much water as you'd like in terms of its weight to work your major muscles of your upper body. There's very simple bicycle machines that can lay flat on the floor, and while you're sitting watching television or doing your crossword puzzles, you can make your legs get in motion. So you don't have to go to Gold's Gym.
Right.
To
Because I think
I always
sometimes
recommend the cans of soup, actually.
cans of soup, okay. Or peaches with heavy syrup.
All right, sure.
that's a good idea. I mean, little things like that I think can make things easier for people at home and not be intimidated by having to go out to a gym. It's another thing to do, especially in the bad weather, so that's good. So you're trying to prevent rehospitalization too. That is another goal. I heard you say people bounce back into the hospital with this disease.
Yeah. So really, gauging people who are recovering as to where they are and where we want to get them to be, and having them with the right network of providers, so that if things aren't right, that they know who to reach out to, so that they're aware of warning signs, so they don't wind up back in the hospital, and maybe they can actually come straight to a Marquis facility if it's, we'll call it a minor dip as opposed to a complete flare-up of symptoms.
Right.
So really being aware of symptoms and changes.
Early on, catching them early on, such as if you're more short of breath than usual, or the characteristics of your sputum production might change, your exercise tolerance. But again, you always have to be aware of good hand hygiene, being out in the public, communal areas,
Right.
kids that come back from kindergarten or
Air
daycares,
travel.
air travel,
That's true.
little snotty kids.
Yeah.
All right.
This is true.
Yeah.
Well, there's people out there probably that don't have a doctor. They don't have a Dr. Adam Smith. How would somebody go about finding a doctor? I mean, obviously you can ask your primary care physician, but if it was just something, they're seeing this today and they're saying, geez, I think I have some of those symptoms. I'd like to see a pulmonologist. What would be a good way for them to find one?
I think the usual case would be to ask your primary, because I think most of the physicians in our area are part of networks where you have access to specialists, and I think in our area we're fortunate and we do have a lot of great specialists available. So finding someone that is connected to your primary doctor is probably the easiest first step, and there are folks that are usually outside of our geography that need to take more on their own plate and start making calls, and I've met some patients that way where they just they couldn't get a doctor's appointment locally, so they went on their own and said, who can I find? And
Right.
They looked online and found some a certain system and found some names and called around.
I think you had mentioned too, Steve, there was
Yeah,
a
I'm
way.
sure there's some websites, Find a Physician, I think,
Right.
and you can look into the background of the doctor and where he trained and any complaints that might be against the individual.
Sure. But I think probably first step, check with your
Check
primary
with your primary
care.
physician, because like he mentioned, you would have a pulmonologist in that healthcare network, I'm sure.
Right. So what are some of the goals of optimal care and factors and things that they play?
In a nutshell, stay clear and clean.
Yeah.
You gotta quit smoking.
Quit smoking.
Nicotine used to be used as an insecticide.
Oh.
Cigarettes have countless numbers of carcinogens in them. And the kids nowadays, they think vaping is a good option. It's not. If you're vaping nicotine, nicotine is still getting into your system. Tobacco farmers can get nicotine into their bloodstream merely by touching the tobacco leaves.
Wow.
So you can tell there's toxin in there.
Right.
So if you're a smoker and you have lung disease, if you continue to smoke, expect to be going back to the hospital time and time again, regardless of how good your medical management is.
Right.
So cigarette smoke, exposure to anything, as I mentioned earlier, that might be airborne.
Well, those are some good things to think about. So I was thinking we could talk about what are some of the things in the future? Any new developments or any new treatments that are out there, things that we're looking at, that short of having a lung transplant, right? I mean, there aren't that many things you can do. If you have your lungs, you need to take care of them.
Yeah. So you know, when it comes to medications, there hasn't been any revolutions in terms of treatment options in many years, but there has been an interest in what we can say minimally invasive lung volume reduction. So years ago, it was discovered that if someone has an area of emphysema that's more pronounced than other parts of the lung, if you actually surgically resect it, the rest of the lung works better.
Yeah.
So that's surgical lung volume reduction. Sounds scary, right?
Right.
So and indeed it is. And while in studies it was shown to have benefits, most of us are loath to refer people for surgical resection because these are sicker patients to begin with.
Right.
So that never became a very viable option. So what doctors started looking at instead is could we block bad areas of the lung without cutting it out?
Right.
And there's been significant progress in that space. So there are actually there's one-way valves that are approved for actually collapsing those areas of lung so that the rest of the lung can work better. Yeah. Now this is not applicable to everyone with advanced COPD. You have to have certain areas of the lung that are primarily affected. But it's a newer and innovative option for many patients.
Well, that's very encouraging. It really is.
Another thing on the high-tech side for pulmonary support is portable BiPAP therapy. I had mentioned that earlier, where BiPAP has two pressures to help ventilate the lungs.
And it has a mask that you put on a mask.
Well, you can have pillows, nasal pillows, which are a little more discreet and less claustrophobic. But they do have portable BiPAP units that can either go into a backpack or clip to your belt. I mean, the technology is incredible.
Great. Yeah, and insurance will probably cover something like that.
Yep.
Yeah. So I do want to comment on one thing, and that is, even with these options, these are modest, helpful options, and unfortunately, we can't regrow lung function that's been lost. And every now and again, a patient will come in having found online about options for implanted stem cells in various locations, and they've asked me my opinion on that, and I've had to strongly advise against it, where there are really some opportunistic organizations or companies that are promising the world for implanting your own stem cells, so it can be.
And there's been
there's certainly no FDA approval for such therapies, and no studies to demonstrate any kind of efficacy. But people will come in occasionally. It's my office with a pamphlet saying, "I want to go do this." No one's been able to help me, so these guys have promised to do so.
Right.
And
I'm sure with the disease, people get desperate and want to be cured. Unfortunately, it's not a curable disease, right?
Right.
So.
It's manageable, though. So we're optimistic.
Well, that's good to know. You know, if you do have this horrible disease, it's manageable, and there are things that can be done
And
about
talking about it being manageable, I also like to present it in a optimistic light. What I tell folks in my office is that I find that we have three pillars to our cardiovascular health, and we can do pretty well with one pillar being down. But if two take a hit, we find ourselves in trouble. So I think about heart function, I think about lung function, and then I think about our musculature. So I've cared for advanced cardiac patients who have had very poor heart function, but they had okay musculature and good lungs. And numerically, you'd be astounded as how well these folks were doing. Similarly, with our folks with severe COPD, if they can maintain good heart function and good musculature, they can do pretty darn well. So that's why staying on top of things, and look, nothing gets easier with time.
Right.
So really staying on top of it all the time, which is not easy,
Right.
is the best way to manage it.
And Dr. Smith mentions how important cardiovascular function is, but lung disease usually doesn't stand by itself.
Right.
Your heart and your lungs work in conjunction with each other to provide the oxygen and to eliminate the carbon dioxide. If your lungs get too diseased, your heart has to work much harder to get the blood through the lung network and back out to the body. And oftentimes you suffer problems with pulmonary hypertension and other cardiac problems that are a result of the primary lung disease. So that needs to be managed as well.
Absolutely. Such good information. I've really learned a lot speaking with the two of you today.
Well, we'll
I
do
wanna
it again.
Thank you so
Yeah,
much for
it's been a
coming on the
pleasure.
show. And, I just hope you have a great rest of the summer.
You
Thanks
too.
for coming on. And thank you for joining us. We'll see you next time at Marquis Presents Your Key to Healthy Living. Thank you and have a great day.
Bye-bye.